The next chapter, chapter 3, is inflammation. There are two components of inflammation, acute and chronic. We're going to start with acute inflammation. And in general terms, acute inflammation is an immediate response to some type of injury. We talked about injury in chapter 2. And this part of the immune system we call the innate. The other component, as you recall, is the adaptive. And the important variable that dictates whether it's innate versus adaptive is, on the x-axis, is time. So when we talk about the innate immunity, we're talking about immunity against foreign invaders, microbes. So when you talk about each organ system, they have different ways of dealing with microorganisms and the microenvironments. So how do they do it? One, you can think of 3 organ systems that have secretory products, like the urinary tract, the GI, and respiratory. There's a constant flow of secretions. These secretions, if they're disrupted in a disease process, can lead to an increased propensity to develop an inflammatory response to that microbe. So it becomes important to remember the histology of the various organ systems, and if they're breached by a disease process, then you have an increased likelihood of developing an inflammatory process. So the barrier, the epithelial barrier, like the GI tract, respiratory tract, urinary tract, your skin, all these different organ systems that have an epithelial lining can develop an inflammatory response, especially if that epithelial barrier has been breached. Another component of the innate immunity is essentially, what we're going to talk about in acute inflammation, are acute inflammatory cells, neutrophils, polys, segmented white blood cells. They all have different names, but it means the same cell. And this cell becomes very important. The other cell that's going to be in the shadows initially will be the macrophage. The macrophage is a critical cell not only in both acute and chronic inflammation, but as we talk in chapter 4, it's also responsible for guiding through the process of tissue repair. So when you think of innate immunity, you have to think of the variable of time, because it'll be reflected in the clinical vignette or in a clinical patient in their history. Whether it's going to be within hours to days, that's what you think of acute inflammatory process, versus chronic, you think of weeks, months, years, decades. And the cell you always have to think about is the macrophage, which we'll talk in more in depth when we get to the chronic inflammatory state. What are the cardinal signs of inflammation? They become critical since the history, which will include the symptoms and signs, will be critical. One is rubor, or redness, and what is that a major component due to is increased vasodilatation, because you're releasing a variety of chemical mediators that we'll discuss shortly, like histamine, serotonin, prostaglandins like PGI2, that will lead to increased vasodilatation, and that becomes critical because it's going to deliver more oxygen and nutrients to as well as temperature will increase in the inflamed area. Another critical component of acute inflammation, as you recall, is heat. And the heat is generated by several processes. As I just mentioned, it can be due to increased blood flow, but remember there are a variety of chemical reactions. And if you think back, chemical reactions, they release energy. So there are a lot of exothermic reactions taking place in the acute inflammatory process that will lead to increased heat or calor. Another important component of acute inflammation is reflected in the area swells, and we call that basically a tumor is the old term. Swelling means tumor, so if you had a bee sting or if you're pregnant and you got a swelling or a bump, as it's called today, that would be called a tumor, but we don't use it in that setting now. We use it, we use the word tumor for neoplasia. And that's second component here is increased vascular permeability that leads to edema, which we'll also discuss in more detail when we get to the circulatory pathology, chapter 5. But in this case, there's increased vascular permeability that's going to allow the influx of important plasma proteins as well as inflammatory cells like acute inflammatory cells and monocytes, macrophages coming into the tissue. Another important component of acute inflammation is pain or dolor, and this becomes another important part of inflammation, and pain is good because without pain you would not recognize that something is abnormal with that tissue. And when you think of a diabetic who has sensory neuropathy, where they're not able to sense pain, the inflammatory process can proceed and it can have deleterious effect leading to amputation or the death of the patient because of sepsis. So pain is good. And what does it do to? You think of things like bradykinin that's released. You also remember because of the swelling or edema that one sees in the inflamed tissue is going to stretch the tissue and also cause the initiation of sensation of pain. And pain is relative because, as you remember, women tolerate pain much better than males. And that will become important when we talk about an acute myocardial infarction. Another important reflection of the acute inflammatory process is the loss of function, or functiolacia. And basically, when you have, obviously, if you sprained your ankle and you have an inflammatory process there, you're not going to be able to stand on your foot because of the pain and swelling. So that is what we think of in loss of function. And so each organ, depending upon what its biochemical as well as physiologic state and its function within the body, will be affected by the inflammatory process once it involves. But remember, these are roadmaps that are critically to understand because the names may change in the organ systems, but acute inflammation is still acute inflammation. And acute inflammation, as we just mentioned in the previous slide, is hemodynamic changes. So initially you're going to get a transient vasoconstriction because there are mediators like thromboxane A2 and the leukotrienes that are released that are vasoconstrictors. But it's a transient vasoconstriction because you essentially need to have the vasodilatation. And that's going to be mediated, as I mentioned previously, by histamine, bradykinin, prostaglandins, as well as not mentioned on the slide, but serotonin can also. And serotonin is a very interesting molecule because, as you know, it's a neurotransmitter in the CNS, but it also, depending upon the amount of muscle tissue, if you inject it into the venous side, it tends to be a vasodilator, but if you inject it into the arterial side, it can be a vasoconstrictor. So it depends. And that's also true of prostaglandins, but for this examination, you just have to remember the majority of prostaglandins, except thromboxane A2, are vasodilators. And then as the second component, as I mentioned, there's increased vascular permeability to allow increased plasma proteins that are critical to the acute inflammatory process that's going to take place, as well allowing the inflammatory cells, the acute inflammatory cells, to go through the vessel wall. We call that diapedesis, and we'll describe that in more detail when we get to that component. And obviously, these chemical mediators will increase the permeability. And like I mentioned, these vasoactive amines, histamine and serotonin. Bradykinin is part of the kinin cascade. Remember, the prekallikrein is made by the liver, and the liver is really an immunologic organ, and we'll show how important it is in the acute inflammatory process. There are the release, as you recall, from arachidonic acid, break down the plasma membrane of cells, to leukotrienes as well as prostaglandins. And here, when you think of leukotrienes, you think of the series of C4, D4, and E4, but there's also a B4, and we'll talk about that more in depth. And then this increased vascular permeability is going to allow the endothelial cells to contract, and the pericytes that are on the outside of the vascular bed, they're like the capillaries and postcapillary venules, will cause contraction. And this will facilitate the increased vascular permeability, as later on you'll allow the diapedesis or the acute inflammatory space getting to the extravascular space where the inflammatory process is taking place. And so if you have direct endothelial cell injury, as you recall from microbiology, you think of endotoxin that's released from gram-negative sepsis, for example, that can damage endothelial cells and facilitate the permeability as well as the extravasation of acute inflammatory cells into the extravascular space around that blood vessel that's involved. And the leukocyte, because it contains a variety of molecules that can cause injury to the blood vessel wall, can also damage the blood vessel wall and cause complications like thrombosis, hemorrhage into the tissue if there's too much of an acute inflammatory response. When you have the vasodilatation, you'll have more blood flow into the area and therefore allowing increased viscosity of red blood cells, white blood cells, and this allows them to get in close proximity to the endothelial cells, and they immigrate through the vascular wall at what site? The postcapillary venules.